Okay, we are now live streaming. Welcome to everybody on Facebook to this version of the Bighearted Warrior Unite Tour. This stop, UPMC. So we're out in Pittsburgh today, even though some of us are in New Jersey, some are in California, and we're not really sure where everybody's joining us from yet, but we're going to find that out in a little bit. So we're going to let everybody get into the room. It is just start time, and we are streaming on Facebook. Couple of housekeeping messages. If you are watching on Facebook, you will not be able to ask questions. It just dawned on me that I forgot to put the link into the Zoom room. If you need to join the Zoom room and ask a question, please go to the HCMA website and register, and you will be sent a link, and our staff will be able to assist you. So right now we're going to just see what we've got going on in our participants. And okay, we've got 42 in here right now. So welcome everybody to the Zoom room. And the number is growing. So we're going to just do a little bit of housekeeping while we get going here tonight. I want to take a moment before we get started tonight to thank our sponsors of this event: Boston Scientific, Invitae, Bristol Myers Squibb, formerly Myocardia, and Cytokinetics. We could not do these events without their support. These are free educational events to all who view. So we thank our sponsors for their gracious support and allowing us to run these programs. Okay, tonight, my co-host is going to be Timothy Wong, who is the director of the HCM program at UPMC, and we're going to get going here in just a few moments. I'm still waiting for some population to pull in. And while let me go back up here. While we're waiting on everybody to join, just a review of what's going to happen tonight in our agenda. And I want to take a moment before we jump into that and say hello and introduce everybody to Amy Mann, our meeting coordinator, who's coming to us now from California, newly transplanted. Well, formerly transplanted 4 years ago. How many years? 3 years ago, heart transplant, and last week transplanted to California. And Julie Russo, our volunteer coordinator, who's joining us tonight to help us coordinate this event, who's coming to you from Pennsylvania. So we've got our staff here, so other side of Pennsylvania from Pittsburgh, but Pennsylvania is very well represented. All right. And on that note, I am going to stop my screen share for just a minute to give Tim an opportunity to say hello and introduce us to who's with us this evening from his team. Oh, Brian made it. Good timing, Brian. Okay, Tim, off to you.
Thanks so much, Lisa. Can you hear me?
We can hear you.
So we just want to send a warm welcome from our team to the audience. We have Kim Castro, who is our main nurse coordinator, Genise, our nurse practitioner, as well as several key faculty in our program who really just want to continue this collaboration that we've had for the past decade with the HCMA and keep on with patient outreach and education efforts. So we're really delighted to just spend a couple hours this evening just sharing some of the latest news about HCM and also just reviewing some of the common recommendations for living well with HCM. In both the adult and pediatric population. So thanks again for having us join you on this tour, Lisa. And we definitely want to continue the collaboration moving forward.
You just made me feel really old by saying it's a decade, but I've known Mark a quarter century almost, so that even just makes me feel worse. So thank you so much for all of your partnership over the years, and for taking the time out of your very busy schedules to take time on patient education so that we can all learn together. So I'm going to jump in and I'm going to do a quick talk, which is very different than any of my other Bighearted Warrior Tour talks. So if you think you've heard this before, I assure you, you haven't, because literally it was changing up to a minute or two before I logged on, because there's a lot going on in the HCM world in case you hadn't heard. So I'm going to go into, I'm sorry, I did forget one other housekeeping issue. While we are streaming live on Facebook, you cannot ask the questions, as I said earlier, but you also, when you're in the room itself, there's a Q&A button at the bottom. If you want to post a question, you can do so at any time during the meeting. We will maybe answer your question and one of the faculty members can type in an answer, or we will wait to the end of each session to actually answer those questions. At the very, very end of the night, if there is a question that you want to ask, but don't want recorded, or you don't want it to be on the internet for the first time. So we now have a transcription for our hearing impaired audience. And we are sorry that we did not know about that feature in the past. We have it now, and I feel much better about things because that's done too. Okay, now, where was I? I was here. All right, our faculty can mute themselves and hide their cameras if they want. They're welcome to stay pictured if they would like to, but when we're done, you can all pop back online with us. So tonight we are going to be talking about a number of issues. We're going to talk a little bit about HCMA services and some big stuff going on here. We're going to talk about living with HCM. We're going to talk about sudden cardiac death prevention and the new guidelines, family screening, big topic. And then we're going to talk about some exciting stuff about HCM therapy, what's coming up. I'm going to tease a little bit on that in my talk, but Tim's going to jump in a lot deeper on that, and then we'll take your questions. Okay, so I'm going to start with some basics. Many of you who are here tonight have been diagnosed with something other than HCM to explain the symptoms of HCM that you're experiencing. I like to start with this slide for the simple purpose that maybe your family is watching with you, or maybe a healthcare provider is watching tonight, and we can really explain that we are the island of misfit toys in a sense. We've been misunderstood for a really, really long time. Many of us have been diagnosed with asthma. Athletically induced asthma is the most specific. Panic attacks, anxiety attacks, depression, mitral valve prolapse, and 51% of us have been told we had an innocent murmur when in fact it was hypertrophic cardiomyopathy all the while. So if you were one of those people who were misdiagnosed and misled for a period of time, welcome to the home that you belong in, and we're here to help you through that process. Okay, so next up, we're going to talk about the prevalence of HCM. We used to think it was 1 in 500. We use that number a lot. However, that was based on echo data from the 80s and 90s. We now have MRIs, we now know genetics, and we now know HCM to be far more common, possibly as much as 1 in 250, which means there's over 750,000 people in America with diagnosable HCM. But to this day, there's only approximately 120,000 of us in treatment or care for hypertrophic cardiomyopathy. This leaves a great deal of work to be done to identify the undiagnosed. And we are going to be telling you how you can get involved and work with us on that tonight. Okay, so are we all talking about the same disease when we say the words hypertrophic cardiomyopathy? Sometimes we are and sometimes we aren't. We know that there are a number of sarcomeric proteins, and I know Tim's going to discuss cardiac sarcomere later because we're going to talk about myosin inhibitors, and this is a really hot topic for us. So this is one pathway for HCM, but then there's this whole group of people who get genetically tested, have the same phenotype as these other people. The heart looks the same. However, we can't find a gene. And then there is another group of individuals who have non-sarcomeric genes causing their hypertrophy. So the first step after we go from misdiagnosis of asthma to getting diagnosed with HCM is to make sure you're in the right bucket of HCM and that you're not in a phenocopy or a disease that looks like HCM but has a very different mechanism, that you are either an unknown gene or a sarcomeric gene, because the other ones have different treatments. So how do you best accomplish figuring out what kind of HCM you have? By going to a high volume center of excellence. And that's why we have spent a great deal of time over the past 20 years developing what we refer to as HCMA recognized centers of excellence. I will just talk a little bit about why that's important. This is a slide shared with us from our friends at the American College of Cardiology. This tells you how many patients are in an average cardiologist's practice. And this means statistically that the average cardiologist out in private practice America sees an average of less than 10 patients in their entire practice with HCM. In the next couple of slides, you'll see how we can vary so greatly with HCM that it's critically important that we have a team that truly understands the idiosyncrasies, the complexities, and the rarity of some of our presentations of HCM. So as of right now, there are 42 programs in the United States. We will be launching one later this month. I will tell you that it's a program that I'm excited to have on the team, but I can't disclose it yet because it's their moment to celebrate, and I can't let UPMC celebrate for somebody else. We have 16 programs under review at this time, and we are hoping to get out of our 2020 COVID slump and get back out there and start doing some evaluations on these programs in the next couple of months. And you're going to all of a sudden see this number go from 42 to probably close to 60 in the next couple of months. So fingers crossed that things keep moving in the right direction there. Okay, so what is a center? What is a center of excellence, and what is a HCMologist? So we really do need a gatekeeper in HCM. And it takes a village of doctors to make sure that our cardiac needs, as well as the other physical needs that we have, are met and maintained. So you're going to be hearing tonight from somebody who's one of these subspecialty groups, and that's an electrophysiologist. Lots of people with HCM have an electrophysiologist on their team, but we go down to these buckets and we live in these other areas for a period of time. So we go through imaging and we get evaluated for heart failure. We look at genetics and mental health issues, and we land in these different places for a period of time. But then we have to go back up to the care of our HCMologist or future HCMologists, as the case might be. And we go back up there. Oh, wait, I have to go back to that slide for a second because that's just adorable. Because as we were planning this session, we got a new person in the community, although we've probably got another 25 years of training behind these two. This is Dr. Wong's new baby. So I had to throw the pictures in, and his old baby. Okay, so why is it important that we have a gatekeeper? If patients with HCM get left in the care of one of the buckets, we can miss nuanced changes that occur in HCM. For example, a patient with hypertrophic cardiomyopathy and atrial fibrillation. Yes, an electrophysiologist might be involved in that care, but if that heart muscle starts to fail and we start to lose ejection fraction, the HCMologist needs to step in quickly and take action. So we need to make sure that this team is cohesive, that this team is working together, that they're getting you through all of life's issues, maternal fetal medicine, mental health issues, your colonoscopy, all of these other factors that are your life, your HCMologist needs to be involved with. And I thank Harry Lever for the term HCMologist because he kind of created it and we stole it from him. Okay, so what have we learned about high volume center of care modeling? Well, I'm happy to say that the American College of Cardiology and the American Heart Association in the 2020 guidelines recognize that comprehensive HCM care should be the model where patients get their cardiac evaluations and care. However, they recognize that not every center is created equal, and not all of our HCMA recognized centers of excellence are exactly the same. Some will take care of pediatrics through every aspect of HCM, EP, surgery, alcohol ablation, all the way to transplant, PGD, and beyond. And other programs may not do peds, or they may not do surgery, or they may not do transplant, but they have a really good program and they refer out for those extra services. What the critical thing is I want to bring to everybody's attention is the importance of the hometown cardiologist. I know a couple of slides ago, it sounded like I was being hard on the hometown cardiologist. They should not be managing most HCM care in the opinion of the HCMA, but they are a partner in that care. And the more we bring them into partnership, the more they're going to understand and get educated and understand the value of Center of Excellence care, and they will learn from this experience as well. So we encourage a collaborative agreement. What we know about high volume Center of Excellence care, patients get better outcomes from surgical procedures, they have lower mortality rates. There's a higher likelihood that the patient will be treated with the appropriate medications and therapies and offered the most effective for that anatomy care and treatment. And it's less likely that you'll be on care that is inappropriate or in fact contraindicated for HCM, which still happens to this day in non-center of excellence care models. So here's one of my new slides from tonight. I stopped and thought for a minute about some of the topics for tonight. We're going to be talking about living with HCM. But first we have to acknowledge that life is hard, especially lately. It's been really hard. So there's all of these factors that as a human, we all encounter: deaths of loved ones, selling a home, moving, dealing with children, paying the mortgage. This is life stress. And on top of all of these stressors that we have in our lives as human beings, those of us with hypertrophic cardiomyopathy have all of this on the plate as well. Where do we fit in HCM? What are we dealing with today? What might we deal with tomorrow? So you could be asymptomatic, meaning no symptoms at all, low risk for sudden cardiac arrest, gene positive, and you just need to go to the cardiologist every once in a while. You could be somebody who has a high risk profile for sudden cardiac arrest and need a device. You may have obstruction and are experiencing more symptoms and must go to a more aggressive therapy for your obstructive HCM. You might have advanced heart failure like I did at one point and maybe even have to go for a heart transplant. You might be dealing with atrial fibrillation and stroke risk and anticoagulation management. Or you could be in more than one of these buckets at a time. On top of everything else, we know that's really challenging. And frankly, that's why the HCMA was formed, to help you get the support you need and help clear up this clear as mud understanding of what to do next. Okay, so I have good news. I actually have to move some things on my screen here because I can't even read my own slides. So the good news is good things are coming. Amazing things are coming. But with amazing things like new clinical trials and pending FDA authorizations and maybe even genetic-based therapies, there are going to be some new challenges that we all have to get involved with, and we all have to use our voice to ensure that we actually get to the next step of this process. So if those of you who have seen these talks before, you've never seen these next slides because this hasn't happened to us before. What am I talking about? This is complicated. Tomorrow afternoon, actually tomorrow morning at 11 a.m., we're going to be holding another session live on Facebook. It is going to be about something called ICER. That is the Institute for Clinical and Economic Review. They are currently evaluating mavacamten, the drug that is currently under investigation by the FDA for possible labeled indication. We will hear back from them by the end of January 2022 as to whether or not this can be made available or not. But there's this whole other process that the HCM community has really never dealt with before. And that is an economic review of the feasibility of the availability of mavacamten. I've talked about this a number of times, that while we have lots of reason to be excited about new therapies, there are also challenges. And one of them is getting it to market, getting insurance companies to provide reimbursement for it, and to ensure that it is available at a fair price. And right now, this is complicated in HCM because HCM is complicated. We are going to go through step by step with you tomorrow at 11 a.m. how to make a comment, a public comment to the ICER draft report. We will answer your questions about the draft report. We will show you where to find it. But the trick here is public comment closes on September 15th. So this is really time sensitive. So please join us tomorrow to learn more about that. Why is it important? Every patient has a unique perspective to share. Economists and policy experts don't understand us. We need to know that we have worked so hard to put tools in the toolbox. We need to make sure that they're accessible. And ICER has some people who speak very highly of them and others who are very critical. I'm trying to be Switzerland here and trying to work with them for them to do their job so we can do our job and advocate for you. So it's a critically important topic, and please join us tomorrow at 11 a.m. on Facebook. It will be available on YouTube for those of you who aren't Facebookers by the following morning. So it'll be out there real quickly. We might even be able to get that one up tomorrow afternoon. Okay, I have a new clinical trial. So Monday, they're going to have another presentation live on Facebook with a company called Imbria Pharmaceuticals. And this is a new clinical trial for non-obstructive hypertrophic cardiomyopathy with preserved ejection fraction and who develop refractory symptoms to drug therapy. And they're going down the transplant pathway. And there's not a lot of other options left available. So this drug will be explained in detail by their Chief Scientific Officer, Michael Freneau, who I'm happy to say I've known for almost as long as about the same time as I've known Mark Estes, about 22, 23 years. And we're also going to be joined by Principal Investigator Martin Marin at Tufts, who is already enrolling some patients in the trial up at Tufts. We are going to be launching our recruitment efforts to assist with this trial on Monday. So if you're on our list, if you've joined the seminar, you'll be on the list to get the survey with the inclusion and exclusion criteria. And with a couple of clicks, we can help facilitate the communication between you and the clinical site coordinator to see if this is a good trial opportunity for you. So you can learn more about this new drug on Monday, the 13th at 6 p.m. Eastern time. And we hope that you will join us for that session as well. Another thing I want to talk to you about tonight is something critically important to one of the points I brought up earlier, and that is the undiagnosed. The HCMA is on a very targeted mission to help find the undiagnosed, and we're going to do that through legislative advocacy. So first thing we need y'all to do is sign up, and I'm going to go through a couple screens here to explain how you can sign up. So you go to forhcm.org, this is our website, and you will click on Get Involved, which is in the Programs menu. And then you click on that little button that says Volunteer with the HCMA, and that'll take you to a screen where you can check off exactly where you want to spend your time. And we currently have 3 projects that are accepting volunteers. A couple more will be opened up later this week, actually next week. And you just click on that and you're on our list, and then we can start communicating with you. We are also going to be launching this survey. Yes, I did launch it. This link works. We'll put this up in the chat. Julie, if you could do so, if you're still with us, pop that Survey Monkey link in the chat, and people can take the online survey and become a volunteer that way. We also have other great ways for you to get involved and help support us. It's our 25th anniversary, and we have 25 for 25. And we also have our first annual virtual 5K, and you can get all that information right on the website on how to participate there. So I'm very excited about these new efforts. If you're watching us on Facebook, you know where you are. If you're not watching us on Facebook, we encourage you to join the conversation in one of our discussion groups. We also, have Sweden set up as our HCMAI, our international programming, where we now have a Swedish language Facebook page that is linked to our main page. So there's lots of ways to communicate. Our private group is approaching 8,000 participants right now. So I encourage you to join the conversation if you're a Facebooker. We're also on Instagram and Twitter. We have revamped yet again our online discussion groups, and you can find all of them available on the website. We actually cut down the number of events, and we're tag teaming our discussion group leaders together so that we can have a little bit more robust conversations. We ask if you sign up for an event that you show up for an event, because we limit them to 25 people per session. And a couple of people have no-showed on us a few times, and that's not cool to our volunteers. So please, if you sign up, show up. Okay. Tomorrow morning or tomorrow afternoon at noon is Tales from the Heart with Marty Marin, which is our podcast series. I'm hoping to grab a couple of our panelists tonight into some of our future podcasts where we talk about all things HCM. Tomorrow's topic is going to be clinical trials and the future of HCM, which kind of continues the theme of tonight and the ICER conversation at 11 a.m. tomorrow. So we hope you join us at 11 and 12. Okay, and I don't know why, there we go. If you have not yet visited our externally led patient-focused drug development meeting video, which is available on YouTube, I encourage you to do so. You're going to hear directly from families and patients, And you're going to see some really interesting statistics. There's a complimentary report, the Voice of the Patient report, that goes right along with the actual meeting. And together you can get a very good understanding of what it's like to live with HCM. I don't know what the heck just happened there. My apologies. And very goodness, my computer is not behaving today. I'm going to finish my comments here and thank our partners at UPMC for a decade plus of service and partnership, and all of our Center of Excellence partners. Also to our full staff, board, and volunteers, and of course to Randy, my donor, without whom I wouldn't be able to be with you today. Special announcement, we still have a couple of the 23andMe kits available for anybody who purchases a membership, and it's 1 kit per membership. No, it is not HCM genetic testing. We have the Invitae free testing program for that, which you can find out about on our website. And with that, I hand it off to the amazing team at UPMC, and I am done. There we go. Tim, who do we have up next?
We're going to have Kim just start off with a very brief introduction to introduce everyone to our program. And I think a lot of our patients have heard Kim's voice over the phone, but I wanted to make sure she gets some prime time because she is one of the unsung heroes that makes our center work and does more work than most of the rest of the hospital.
Kim, off to you.
All right. Well, thank you. But really, I don't do as much as the rest of the team does, but this is all new to me, so please bear with me. I'm just going to try to share my slide here. Let's see. Did that work?
You're in the design mode. So if you just want to go up to the top and you can hit that little icon next to the circle arrow with the little screen with the arrow.
Oh boy.
Or you can go to the bottom of your screen and hit down there where it's got the present mode. There you go.
Does that work? Okay. All right. Sorry about that. My name's Kim Castro. I'm the primary nurse care coordinator here at the UPMC HCM Center. On behalf of everybody here, I'd like to welcome you and briefly introduce our program. We'd also like to acknowledge the Hartley family for helping us to make this educational collaboration possible with the HCMA. So let me go to the next slide here. There we go. Okay, so we've been working with the HCMA for over a decade now, and we're proud of the milestones that the collaboration has achieved. As we've grown, some of the unique aspects of our center is outreach toward for underserved patients with HCM, such as the Amish community. Also partnering with McGee Women's Hospital to form an active cardio-obstetric collaboration for our patients, and also participation in multiple trials for novel medications related to HCM. Okay, so please note on the bottom of this slide that this was made by Dr. Wong. The people that do all the hard work, my name should be at the bottom, but this is our team. And it's grown and changed over the years, but we're all committed to providing a medical home for our HCM patients. For any new patients who come to see us, Dr. Tim Wong, Genise Green, nurse practitioner, Dr. Jason Becker, or Dr. Randy Jeffrey perform the initial evaluation, and then any additional consults are contacted as needed. Okay, and then lastly, this is our contact information for those in the audience who already follow with us. These numbers should be familiar. But if you're a new patient who's interested in coming to see us, we'd be happy to take your call. So please reach out to us and we'd be happy to get you scheduled. Thank you for listening, and I'm going to turn it over to Genise.
Kim, I think I need you to stop sharing your screen and then I can take over. There we go. Perfect. All right, so my name is Genise Green. I'm a nurse practitioner. I work very closely with Dr. Wong and Kim and everybody else that we've talked about. I am going to go ahead and share my screen. And see if this works. There it goes. Okay, so what I'm going to talk about tonight is some common questions that I often encounter with a lot of our patients when they come in, especially in their initial visits. So people are diagnosed with hypertrophic cardiomyopathy, they're sent to us, and one of the biggest questions they have is, what activities can I safely do? So I have no disclosures. And some of the common questions we run into under that heading are, what can I do to exercise safely? People wonder if they can still go for runs or go to cycling classes. Other people think that with hypertrophic cardiomyopathy, it's not safe for them to exercise anymore. So they're trying to get out of gym class, so to speak. And you can see on here just a lot of the common questions that we run into in regarding activity levels. Also, we get questions about supplements, medication, diets that they could follow to try to help with management of their HCM. And then also I'll touch on pregnancy, as we often are meeting young women and men who want to start a family, and they have a lot of questions about how they can safely get through pregnancy. So that being said, there are new guidelines about exercise recommendations, which we are trying to follow when we talk to our patients in our clinic. So the current recommendations are that everybody should participate after a collaborative discussion with their physician, of course, try to participate in some sort of exercise program and from mild to moderate intensity, because this overall can improve our quality of life, fitness, physical function, and just overall health. So generally, we recommend you try to aim for about 150 minutes of mild to moderate aerobic activity per week. And then we also recommend some strength training. So to further kind of detail that, then people are asking, well, what is mild intensity exercise versus moderate intensity exercise versus vigorous intensity exercise? So mild intensity exercise isn't going to feel hard. You're going to be able to participate in it without breathing hard. You're going to easily be able to carry on a conversation. Some examples of this are going for like a leisurely walk, swimming, biking, yoga, Tai Chi, Pilates, all of those sorts of things. Moderate intensity exercise is going to feel a little bit hard, but you're not going to be gasping or out of breath. You're going to have your heart rate and breathing increase a little bit, but you should still be able to carry on a conversation, but you wouldn't be able to sing or be, exerting yourself that much. And additionally, one thing that we often tell our patients is they should be able to count from 1 to 10 in one breath while they're exerting themselves at this level. So this would include some of the activities that I listed there, including doubles tennis, which is something that I like to participate in. Finally, vigorous intensity exercise is something that there is still not a lot of data. And so we aren't able to say that people can participate in this safely with a diagnosis of hypertrophic cardiomyopathy. So our current recommendations are against engaging intense exercise such as soccer, basketball, track, where you're sprinting, football, and really even trying to strive for personal records or competitive sports. And we often get patients who want to engage in, or sometimes we get patients who want to engage in competitive activities, and that's something that they should discuss personally with their HCM specialist. The next activity that we like to recommend is a weightlifting activity, as this can help promote a healthy lifestyle. And what we recommend is that you don't lift anything that's so heavy that you can't perform at least 15 repetitions of. We don't want you exerting yourself or grunting or bearing down, where that would cause an increase in your outflow tract obstruction. So that being said, I don't know what just happened there, but that being said, if you have a known left ventricular outflow tract obstruction, you really want to avoid any maneuvers during weightlifting that would cause that obstruction to be worse, such as, you know, squatting, lunging, or anything that kind of makes you bear down. Another thing we like to talk about in a healthy lifestyle is your hydration status. So in general, we recommend that it's good to stay well hydrated, especially if it's hot or humid weather. This is especially important for patients with left ventricular outflow tract obstruction, where that blood flow gets blocked as it leaves the heart, as becoming dehydrated can worsen that degree of obstruction. Now, for non-obstructive HCM patients, and especially those with like swelling or issues with retaining fluid, it's better if you kind of have a discussion with us or with your HCM specialist to kind of figure out what the best fluid amount is for you, to try to maintain hydration, but not tip the scale, so to speak. So let's move on to pregnancy next. So when we have a woman or family who comes in and wants to discuss future pregnancy and the setting of this diagnosis, we feel that it's generally okay for women with clinically stable HCM to have children and not bring on a lot of extra risk. So we generally recommend vaginal delivery, and epidural anesthesia is usually pretty well tolerated, with a discussion with the anesthesia team to avoid any instances where this could cause any low blood pressure. We generally recommend at our center that we see you when you first get find out that you're pregnant, so that we can kind of outline what we think your risks or might be. And then we like to see you again in the third trimester as your blood volume increases throughout your pregnancy, and it's kind of at its maximal level in our third trimester. And we can kind of make sure that your volume status is stable and that you're tolerating everything well, and we can come up with a good plan for your delivery. Additionally, of course, we would bring in our genetic counselor, who you will meet later on in this presentation. And they're a key component in discussing all of this with our women and our families. Next, we'll talk about diet. And I have had people ask me if there's any sort of supplement that they can take that's natural, that can kind of help prevent any progression of the disease, or any diets that can help prevent progression of the disease. And unfortunately, there aren't any like supplemental or dietary modifications that are specific to hypertrophic cardiomyopathy. But that being said, we recommend following a heart healthy diet that's going to kind of help with your overall health and kind of reduce your risk of developing high blood pressure, diabetes, obesity, all of which can impact your heart health. So that being said, we find that following a diet that's low in carbohydrates, high in lean proteins, vegetables, fruits, are all beneficial in an overall heart health. And an example of this is a Mediterranean diet. And we're not like endorsing that or anything, but it does usually check off all the boxes as it includes like a lot of fresh fruits, produce, vegetables, whole grains, legumes, and like heart healthy proteins. And so just try to avoid foods that are processed, high in sugar or refined grains, and high in salt, because all of that can just be detrimental to your body over time. So to kind of recap everything, to have a healthy lifestyle, whether you have HCM or just in general, but it's good to participate in a regular exercise program, as we outlined, with a mild to moderate intensity. You want to follow a heart healthy diet that's, low in carbohydrates, high in fresh vegetables, fruits, lean proteins. Stay well hydrated per what we recommend in regards to your specific condition, and maintain a healthy weight. Obviously avoid tobacco, recreational drugs, anything like that. And then come talk to us if you're planning on starting a family. I have listed here all of my references that I used to put together this presentation. And that is all that I have for today.
Thank you so much. Ooh. I don't know what that was. I am having technical difficulties. Amy, I need you to take over.
Okay, I think we had a question here. Sorry, something's going on with Lisa's computer. Okay. Okay, I think Lisa will answer that one later. So let's go on to the next talk. So we have Mark Estes up next. If you want to share your screen. We can't hear you, Mark.
I had to stop sharing my screen to come off of mute, but we should be good here in just a brief second. There we go. And let me start at the very beginning here. Well, thank you very much, Lisa, Tim, and the other organizers for the opportunity to present. It's been a privilege really to work here at the UPMC Hypertrophic Cardiomyopathy Center, having joined just now 3 years ago exactly, having worked in Boston at another hypertrophic cardiomyopathy center. And my role here really is one to assist with the team in evaluating cardiac arrhythmias. Lisa mentioned atrial fibrillation, a common problem. The other common problem we come into is the risk stratification for prevention of sudden death. And that's going to be the focus of my talk tonight. So with that, the main source of my information is from the recent ACC-AHA guidelines, where they have really done an excellent job of taking the best available evidence and working it into some very reasonable guidelines relative to risk stratification. And as this group knows, there's a spectrum of hypertrophic cardiomyopathy with many people, perhaps the majority, really having a benign condition in which they're asymptomatic or minimally symptomatic. They have good heart function, the left ventricular ejection fraction. They don't progress. They have normal quality of life, normal life expectancy. There's a group of people who have an intermediate prognosis. They might have atrial fibrillation, as an example. And there is an increased risk of stroke, which we recognize. In that respect, we anticoagulate people as soon as they get diagnosed with atrial fibrillation and look at strategies for controlling the rate or controlling the rhythm as well. In addition, heart failure develops in a selected group of individuals, particularly if their heart muscle function deteriorates. And that can occur in the setting of obstruction, absence of obstruction, and it can occur with preserved left ventricular function or impaired left ventricular function. The spectrum that we can get most concerned about are those with more malignant type of hypertrophic cardiomyopathy, in which there might be a risk of sudden cardiac death. And that's going to be the focus of my talk tonight, really talking about risk stratification with a prior cardiac arrest, family history of sudden death, the thickening of the septum or other portions of the ventricle greater than 3 centimeters, this apical aneurysm, an ejection fraction that's reduced, and something that has come up increasingly is the amount of scar on MRI, so-called LGE or late gadolinium enhancement, as well as non-sustained ventricular tachycardia. And we'll work through these and talk about some of the ways that we screen individuals and how we intervene when we deem the risk to be sufficiently high. Now, this is an important slide that goes back to some of the research now over 20 years ago that looks at the people who die, and you need to keep in mind that it's a distinct minority of people who who die with hypertrophic cardiomyopathy, particularly in contemporary treatment centers. But notice that the sudden death tends to come up at a very young age, in the 15 and 25-year-olds, but continues to be a risk. By contrast, heart failure develops, and then in an era when we didn't recognize the risk of atrial fibrillation, you can see with the light gray that strokes develops in the later population. And this is something we need to be mindful of, in particular, making the diagnosis early, identifying individuals who might be at risk, particularly with athletic activity, and intervening in a way that prevents sudden death and tragic loss of life, particularly of the teenagers and early adults. Now, we've also learned too that if you look at the clinical outcomes of hypertrophic cardiomyopathy patients who get first diagnosed and evaluated over 60 years of age, is that these people do extremely well. Notice that the stroke rate is low, the heart failure rate is low, the sudden death rate is low. And indeed, we very commonly don't even risk stratify individuals diagnosed over age 60, because in some respects, they've already selected themselves as being survivors. So many of my comments are going to be for the younger patient population, typically those less than 60 years of age. Now, we do have an intervention, and this is, of course, the implantable cardioverter defibrillator. It's the only intervention. There's no drug therapy that we know reduces the risk of sudden cardiac death. And we have classes of what we call indications. Now, the class 1 indication is a very clear indication in which there's very robust evidence that supports the use of the defibrillator, and the ICD should be placed. If you've had a prior cardiac arrest, or you've had a life-threatening arrhythmia that results in loss of consciousness, has to be treated, goes on for over 30 seconds, it should be placed. That's very clear. It's unequivocal, a class 1 indication. The class 2 indications are kind of a gray zone, and they're split into the sort of 2A, where we have strong guidance. And in this situation, people have not had a cardiac arrest, but they might have a family history, a first-degree relative who's had a cardiac arrest, if their wall thickness is greater than 30 millimeters. And if they've had a blackout spell or syncope that's unexplained and likely to due to a life-threatening arrhythmia. Now, by contrast, other risk factors such as non-sustained ventricular tachycardia, or on the MRI imaging, when you have that late gadolinium or scar, also can be factored into the decision-making. In general, a single risk factor is considered to be sufficient for having a discussion about a defibrillator. And certainly as you get more risk factors, as we'll see in my pyramid of risk, which I'll show you shortly, indicate the defibrillator becomes stronger. And of course, it's always a recommendation. The physicians and the healthcare team guide and the patients decide. And we'll say more about that with the shared decision-making. The ICD is not recommended for people who've had no prior cardiac arrest, no risk factors. And importantly, as Genise indicated, and individuals who want to participate at a high level in sports, specifically, we say you should not have a defibrillator placed to reduce the risk of sudden death because of that athletic participation. That's a class 3. It is not recommended. It shouldn't be done. So with that background, this is my pyramid of risk. And it looks at the risk on the left side, the ICD indications, and down in the lower red section there, if you have no risk factors, it's really very low risk of sudden cardiac death, extremely low. No defibrillators indicated. It would be a class 3. Red, you don't do it. Now, by contrast, there are some areas here in which defibrillators should be discussed. If your risk is intermediate, a risk of sudden cardiac death, a life-threatening arrhythmia is 1 to 10% per year with a 5% threshold in many instances. It's a class 2B. It should be considered, particularly if there's just extensive scar on LGE. And Dr. Wong may have something to say a little bit about this later on because he's done a lot of the research and knows this field extremely well, but it's something we routinely do in patients with hypertrophic cardiomyopathy to risk stratify, and we use it to guide us relative to other risk factors. Now, if they have a family history, massive LVH, blackout spell that's unexplained, the apical aneurysm, non-sustained VT, or low ejection fraction, we do consider that to be a stronger indication. It's reasonable, and I think most experts would start the discussion and come on the side of recommending defibrillator. And very clearly, if somebody's had a prior cardiac arrest or sustained VT, they should get a defibrillator. So some pretty clear areas shown here in green in which the indications are strong. In red, no indications, you shouldn't have it. And then an area here in which there's shared decision-making shown in yellow. Now, we have two options for the defibrillator, and many of the participants are probably aware that we have, as shown on the left side of the slide, the transvenous, and on the right side of the slide, the subcutaneous defibrillator. The transvenous defibrillator has been around for a long time. It has some advantages, including the ability to pace the heart if the heart is predisposed in any way towards a slow heart rhythm. It also can provide pacing for certain arrhythmias coming from the ventricle that would terminate the arrhythmia without delivering a shock. It also has the ability to place an atrial lead, which can be helpful for discriminating the arrhythmias and for pacing the atrium. The defibrillator that is subcutaneous, as shown in the right slide, does not have pacing capacity. It only can shock, but it has the major advantage of not having a lead within the endovascular system. And the subcutaneous defibrillator, I think it's well accepted now as being equal in terms of sudden death prevention to the transvenous for high-risk patients. And at the top of the list is the hypertrophic cardiomyopathy patients who tend to be younger, who tend to be at greater risk over the long term, decades of the endovascular lead, with survival of leads about 60% at 20 years when they're placed endovascularly. Shown here is an X-ray of the subcutaneous ICD in a patient with hypertrophic cardiomyopathy, completely extravascular. And of course, there are other groups of patients too that are beyond the scope of the discussion tonight who tend to be young, like Wong QT, Brugada. Older patients who are particularly high risk for infections will many times go with the subcutaneous ICD if they've had a history of bacterial infection of the heart, endocarditis, so on. But I'll show you from the data that the ICD is very strongly recommended in certain groups of people, and you have a choice of either transvenous or subcutaneous, provided with the subcutaneous that you have adequate sensing. And we sense with a lead that just represents a bipole with a primary and secondary and alternate vector. And with this, we have to screen patients, making sure that they are going to be acceptable, that their electrical activity of their heart, their depolarization or QRS, and the T-wave fall within a certain range. And ideally, with the hypertrophic cardiomyopathy patient population, we like to screen them and have two leads be acceptable: lying down, supine, sitting, standing, and then with exercise. And when we have all four positions with two leads, we're very comfortable that we're going to have excellent sensing. But there are a minority of patients with hypertrophic cardiomyopathy and other conditions in whom the sub-Q defibrillator cannot be used because the EKG on the surface where we record it from is inadequate. So that has to be screened, and it's roughly 80% of hypertrophic cardiomyopathy patients in whom we can get two good leads in three positions. Now, the subcutaneous ICD was developed over a period of 15 years with multiple trials, but I'm showing the more recent trials in which patients were randomized to standard transvenous devices versus subcutaneous. And in particular, the Praetorian trial and the Untouched trial, very recent trials, which, as you can see, had 1,500 patients, in which there was no difference in sudden death rates between the subcutaneous and the transvenous devices in patients who were candidates for the two. But I think in particular, what we're interested in is the major concern about the sub-Q ICD, which is inappropriate shocks. If you look at the more recent trials, such as the Untouched trial, shown here in 2021, and the Praetorian trial, you can see that with the new filters and algorithms they have with the transvenous devices, the inappropriate shocks, here shown as IAS, on an annual basis, are as low as the best trials done with the transvenous, which is the MADED RIT and the Praetorian. And in fact, in the Praetorian trial, there was no statistically significant difference. So with the current filters and with appropriate screening, the concern about inappropriate shocks really is not there anymore for subcutaneous ICDs with appropriate screening and with the current algorithms which filter in lower heart rate ranges to make sure that there's not inappropriate therapy given for either fast heart rhythms coming from the upper chamber or from muscle activity detected by the device. Very importantly, if we look at the patients with hypertrophic cardiomyopathy who have received ICDs, you can see that there are several thousand, and they have all come to the same conclusion, is that if the devices are used to prevent sudden death, or if they are used in individuals who have survived sudden death, the outcomes are favorable. There have been no prospective randomized trials in which we put defibrillators in some patients with hypertrophic cardiomyopathy and not in others, because that would be unethical. These are all observational data, but very, very robust. And I think that everyone with hypertrophic cardiomyopathy who has risk factors and is considering a defibrillator should have that discussion with their team, their hypertrophic cardiomyopathy team, about which one makes the most sense for them. And it gets into the shared decision making, which is a class 1 indication. It is something that should be done between patients and their healthcare team, looking at the risk and benefits of all the options. And as this group knows, the engagement of the patients to express their own goals is particularly relevant in the management conditions such as hypertrophic cardiomyopathy. And the outcomes are best when patients are very proactively engaged in making every decision. And in many instances, the patients are extremely knowledgeable and challenge the knowledge of the physicians, which is a good position to be in as a patient. In addition, this assessment continues to evolve as new markers come in. Apical aneurysms, for example, are something new. Decreased LV function, even if it's just less than 50%. The LGE, the extensive gadolinium enhancement, are all relatively new. The communication about the presence of the risk factors, but the magnitude of the individualized risk is absolutely key, and enables the patients to make the decision that's right for them. Now, looking forward, where are we going? Well, one of the ways in which research is progressing, and this is the Boston Scientific device, is with a implantable leadless device in the right ventricle, which communicates with the subcutaneous ICD, allows for pacing for slow heart rates, allows for pacing for unstable fast heart rates coming from the ventricles so that you can actually use the pacemaker rather than the shock. Now, this is in clinical development. It is not available for clinical use, but it is technology that is progressing rapidly and likely to result in one of the limitations of the sub-Q ICD being addressed with a separately implantable pacemaker without a lead, which avoids the limitation of the lead long term. In addition, There is also a device being developed, as you can see here, by Medtronic, which overcomes the limitation of lack of pacing with a implantable device with a coil, which you can see, which is used for sensing, but it's placed underneath the sternum with the introducer that's shown on the right side, that long tubular thing. It does not require open heart surgery. It can actually be done in a laboratory by an electrophysiologist. And with that placed under the sternum, and in the lateral x-ray, you can see it here under the sternum with the device here, you can pace not only for slow heart rhythms, for fast heart rhythms as well. And so these are technologies that are evolving very rapidly and likely within the next several years will be available as options for hypertrophic cardiomyopathy patients and other patients as well. And I think in some respects, we'll look back at the days of having to put leads into the vascular system as being perhaps fairly primitive. And particularly for the hypertrophs who are looking at decades and decades, many times, of use of these devices to monitor the heart and to treat any arrhythmias. The leads put in through the vascular system are put under immense stresses with 100,000 heartbeats daily. And despite the best engineering in the world, we can only keep 60% of them functioning normally out at 20 years. So with that, I'm going to really kind of wrap up and conclude, turning things back over to Lisa and Tim, by saying that, if you have a class 1 indication, a single chamber transvenous single coil ICD or subcutaneous ICD are both reasonable, and you should participate in the shared decision making with that. And this is actually from the guidelines, a class 1 recommendation as well. A slight caveat might be with a single chamber transvenous ICD, you don't have the ability to pick up atrial fibrillation as well. And I have this discussion very frequently when putting it in, not only with the patients, but with the care team, about whether we should put the single chamber in or have that atrial lead there to tell us if the patient's having AFib and to use it as a discriminator. A little bit of extra risk, a little bit of extra cost, but sometimes that return is worth it. It's reasonable, a class 2A indication, to have a dual chamber device put in transvenously with this need for A or AV pacing. If you've got an outflow tract obstruction, if you're older in which your normal pacemaker might slow down in the upper chamber. Now this CRT refers to cardiac resynchronization, which we haven't gone into, but there are some patients who have electrical activity in their heart that results in the heart being dysynchronous. If you look at my video here, the normal heart should contract, the left ventricle nice and smoothly like this. And with some kinds of conduction abnormalities with hypertrophs, particularly left bundles, the heart beats very dysynchronously, like this. And we can resynchronize it by putting that left ventricular lead in, as I did just a little bit earlier today in a patient with a left bundle branch block. And particularly if the left ventricular function is decreased. So these are some decisions that need to be discussed and considered very carefully. And frankly, they're nuanced. They're best made, I think, not only by the hocomologist, but the hocomologists who work very, very closely with experienced electrophysiologists. Because these are really critical decisions. And the more preparation and knowledge you have up front, the better the outcome for the individual patient. And then the class 2B to be considered is a dual chamber device if the patient has atrial tachycardia or atrial fibrillation. So with that, I'm going to turn things back over to Lisa and Tim. Thanking you very much for your attention. And as questions come in, I'm glad to answer them related to risk stratification, sudden death prevention.
Mark, thank you so much. And
You're very welcome.
thank you. I've had some technical difficulties here. You might notice I have two cameras up right now. I am not on one of them. So that stop record and re-record was a technical glitch. I'm now in my dining room on a laptop, so I apologize for that. And I apologize that I did not have the opportunity to help introduce you, Mark. So we have a long relationship that started with you putting in my very first implantable defibrillator in July of 1997. And it has been a long winding road, and I'm really happy that we're both here to have these conversations today. We do have a couple of questions for you. And the one is actually a little bit, it's a complicated path here. We have a participant who has an epicardial ICD placed after myectomy. I'm going to guess that this may have been a younger person at that time, but now there's a history of atrial fib, atrial flutter, left bundle branch block. If biventricular pacing is an option, how would that work? So we just kind of discussed this, but I'm a little thrown with the epicardial aspect. Is this a device revision type of a situation, or is this a case-by-case assessment that is not appropriate for webinar?
No, I can make some general comments, and obviously they're general comments and not specific to any individual case, but there are patients who have had systems that have been put in at the time of surgery, a myotomy, myectomy, and they're put around the heart instead of through the blood vessels. Those systems can be modified. In many instances, the leads are actually placed in the lateral aspect of the left ventricle, and that's variable depending upon the surgeon and the amount of epicardial fat. But sometimes those leads can be used actually to pace in a resynchronous fashion, and it is almost always possible to use an epicardial system that's been previously placed to get resynchronization. Many times it does require putting transvenous leads in because you have to have a lead at the RV apex as well as the lateral aspects of the left ventricle and an atrial lead. So, these situations vary depending upon the individual placement of the leads, but there's virtually always a way to get resynchronization in patients, even if they've had prior epicardial systems put in. And increasingly, although I didn't go into it, there's something called conduction system pacing, in which we actually can recruit the normal conduction system by putting a lead into the interventricular septum and recruit the left bundle. So many times we don't need to go through the coronary sinus or do an operation with a thoracotomy to place them on the leads, but there's a whole emerging field of his bundle pacing and left bundle pacing, which I think is going to hold a lot of promise to resynchronizing patients and providing more options, particularly those with left bundle branch blocks and impaired left ventricular function who have symptoms of heart failure.
That's really interesting. I'm thrown by some of the technology that's moving forward where we're trying to get leads out of the venous system and out of the heart, but we're willing to put in devices in the left ventricle or the right ventricle that I'm a little curious, how would they get back out if they needed to come out?
Well, as always, Lisa, you're asking very thoughtful and important questions. The devices that are put in the right ventricle are pacemakers, and the lead is actually the interface of the heart muscle with the tip of that. They're about the size of a AAA battery. Yeah. They can be put in, they can last 7 to 10 years, they can be retrieved, and they can be replaced through the venous system with a snare. You don't need open heart surgery. They have many, many advantages. One, they're not prone to infection. We're routinely putting them in patients who have infections in their blood systems with existing leads, and they just are very, very resistant to infections. They do have the capacity to sense the atrium through mechanical contraction of the atrium and synchronize, and you can get about 85% AV synchrony without an atrial lead. So that technology is progressing very, very rapidly. It is commercially available. Medtronic has a Micra, and other companies are working as well. So I suspect probably in the time frame of 3 to 5 years, we are going to be using fewer and fewer transvenous leads and relying on systems like this.
Well, it certainly is an exciting time for electrophysiology. And just when you thought you saw it all, there's more to come. Mark, thank you so much for participating today, and thank you for that excellent talk. Tim, what do we got up next? Because I'm having some technical difficulties here. I'm kind of hoping you guys can help navigate me through this. I wasn't sure if we had a slight change in our agenda. Tim, Amy, somebody help me.
Tim, you're on mute there.
Oh, so I think we have Meredith Jones and Brian Feingold. Meredith is going to start off with a brief genetics 101 and then segue into a presentation by Brian Feingold on HCM in the pediatric population.
Fantastic. Meredith, please share your screen, and I'm going to go on with technical support now.
Hi, everybody. I'm Meredith. I'm a genetic counselor that works with Dr. Wong on the team, and I am working from home today. And as everyone can imagine, with working from home, we've all had challenges, and one is my dog, and he is whining at me. If you all will indulge me for one brief second, I will be right back.
So while Meredith is dealing with the dog, maybe I'll just chime in and, oh, there's.
I'm so sorry. I am back. Okay. So let me share my screen here. Okay. All right. Can everybody see that?
Yeah.
There we go. Okay. So
Looks good.
should be in presenter view now, I hope. Okay. So as a lot of you may know, or maybe not, genetics is sometimes a part of a complete evaluation of a patient when they come to see their physician for an HCM evaluation. And so I have no disclosures. And so the reason for this is that HCM is often passed on in families, and it's caused by changes or variants in genes. And when we're talking about what we mean by variants or changes in genes, our genetic alphabet has 4 letters, A, T, C, and G, and they're all arranged in a specific sequence or spelling. And every gene has their own specific spelling that has to be in the correct order for the gene to work properly. And if there is a change in the spelling, it causes the gene not to work. And so for HCM, there's multiple genes specifically that make the heart muscle, where if there's a change in the spelling, it affects how the heart muscle functions. And so Lisa had mentioned earlier, sarcomere genes or sarcomere proteins. And so genes, what they do is they make proteins. And so if there's a change in a gene, it can affect how the protein is made, and so it affects how the heart muscle functions. The HCM is inherited in an autosomal dominant manner, meaning that there's 50% risk to first degree relatives, and this is in the majority of cases. And genetic testing is available and is best for people who have a clinical diagnosis and or have clinical symptoms of HCM. And that's because if someone actually has symptoms or someone has a diagnosis and we do genetic testing for that person, we're most likely to find a genetic cause for that person. If we're testing someone who doesn't have symptoms, we're less likely to find a genetic cause for them. And, we may be missing something in a family if we're testing someone who doesn't have a diagnosis or doesn't have symptoms. So if you would decide to have genetic testing, there's different possible results that you may get. For, in particular, one is, of course, a positive result, meaning that a pathogenic or likely pathogenic variant has been identified. And what we mean by a pathogenic variant is that this change in the spelling of the gene, we know will cause a person to have a high risk to develop hypertrophic cardiomyopathy. A negative result means that of all of the genes that were analyzed, no variants were identified in any of the genes. So this does not rule out HCM, but it just would mean that at this time, we're not able to find a genetic cause. A variant of uncertain significance is a change in a gene that there is not enough information to make a call one way or the other if it's a pathogenic or a benign change. There's several reasons why this could be the case. Some might be that this change hasn't been seen before in any individuals with HCM. It could be that there's just not enough information on how this change affects the gene or affects the protein. So there's many different reasons why a gene change might be classified as a VUS. But at the time, we don't know the clinical utility. And then incidental findings. And these are findings where it's something that we would get a result and we maybe aren't expecting. So earlier, Lisa had mentioned phenocopies. So that would be an example of an incidental finding. So something like Fabry disease or Danon disease, where someone has HCM, but it's actually caused by a different genetic condition. So that would be an example of an incidental finding. So follow up after your genetic testing results. So for the individual who has the genetic testing results, often those results won't change the treatment, your treatment or management. Your physician will continue to treat you most often based on your symptoms. Of course, that's going to be part of your shared decision-making that we've been talking about along with your doctor and the team. However, results could be useful for family members and could determine if family members need additional screening or not. For example, if a pathogenic variant is identified in the family, there would be that 50% risk to first degree relatives. And if a first degree relative is found to be negative for the family variant, so they don't have it, then they wouldn't need to have any additional screening. They wouldn't be at an increased risk. And so a genetic counselor can help with these next steps by facilitating testing for family members if possible. And then also for your children, they can help with a referral to pediatric cardiology. And so I think now, Dr. Wong, Dr. Feingold's going to discuss pediatric HCM.
Yeah, so just by way of introduction, Dr. Feingold is the head of pediatric advanced heart failure and transplantation at Children's Hospital of Pittsburgh. And I've had the pleasure of working with him in collaboration with the pediatric HCM population for the past decade. So without further ado, Brian, thanks so much for giving up some of your time to spend it with us tonight.
Sure, it's my pleasure. I hope everybody can hear me okay. And I just want to say thank you to the HCMA, to Lisa, to the adult team at UPMC, which, we're certainly proud to be the sort of pediatric partner with, and hopefully I can, hopefully people are seeing my screen as well, and want to just give an overview of perhaps what we do in caring for infants, children's, teenagers, and occasionally young adults before we get to transition them to the adult HCM program with Dr. Wong and team. So at the bottom of the slide here, I've also just listed our nurse coordinator contact information if anybody wants it. And I have that again at the end of the slide, and I'm sure we can send that out. Okay, so I have no relevant disclosures to this presentation. So very briefly, who are we? So at our program, we have 6 pediatric trained and focused cardiomyopathy expert providers. It includes 5 physicians and a nurse practitioner, all of whom participate in cardiomyopathy care. And a significant segment of that are individuals with or who are being screened for hypertrophic cardiomyopathy. We also have an expert nurse coordinator, Doreen Knop, whose name was on the previous slide and really is the glue that helps keep us together. We also have a cardiac geneticist. So this is a cardiologist with expertise in genetics as well, and access to a genetic counselor, and they can see patients together and are sort of work with our team for perhaps some challenging cases, and I'll speak to that a little bit. And then we have other support, social work support, and are working on more regular access to a psychologist, which I think has benefit to the program. And to our patients, certainly. So who do we see? So a lot of what we see is actually screening. So we've heard from Dr. Estes and Meredith and other folks. The assumption is that many already have hypertrophic cardiomyopathy, and that's clearly the case. But in pediatrics and children, that's not always clear. As Meredith was suggesting, there is we know that much of hypertrophic cardiomyopathy is or can be inherited and passed in a sort of 50-50 probability to offspring, to children. And so we are often seeing perhaps for children of patients followed with our adult colleagues with the question, is hypertrophic cardiomyopathy present? Which is the first question. And then obviously if it is, what does that management look like? How do we care for those patients? So we do see a fair bit of what I would say is sort of cascade screening from affected relatives, parents, grandparents. Sometimes it's cousins, sometimes it's, so it's not always parents, and sometimes it's siblings. And just as an example, in the calendar year 2020, so from January to December of 2020, we saw 158 visits in our clinic, which was about 19%, almost 20% of our clinic volume for that year were these screening visits of individuals who we presume are at some risk of having hypertrophic cardiomyopathy and want to know that so we can then make appropriate recommendations. Screening also comes not just from this cascade of through an affected parent or sibling, but also comes from referrals. So we will see individuals who have heart murmurs, who have abnormalities on the EKG that might suggest hypertrophic cardiomyopathy, or maybe symptoms that again could fit with hypertrophic cardiomyopathy, or have had an echocardiogram, so an ultrasound of the heart that shows an abnormally thick heart. Clearly hypertrophic cardiomyopathy, maybe hypertrophic cardiomyopathy. And so, those referrals come to us in our group, and we see these patients, and we'll do other testing and evaluation as appropriate. So sort of one theme here that we often hear in pediatrics is that kids are not just little adults. So as Meredith just explained a short while ago and was, we discussed earlier in the webinar so far, adult hypertrophic cardiomyopathy is almost always due to a gene abnormality, sarcomeric gene abnormality. So these genes that encode proteins as component of the contractile apparatus, the thing that actually has a heart muscle cell to contract. And this is a diagram of that. And these are common genes, if you will, that are involved in hypertrophic cardiomyopathy. Almost all adults have one of these issues. And most commonly, as you can see, myosin binding protein C3 and myosin heavy chain 7 tend to predominate. In pediatrics, we absolutely see many patients who inherit through the family or are the first in their family to have a new sarcomeric gene abnormality. But we have to also keep in mind that there are a variety of other possible causes of hypertrophic cardiomyopathy. And these causes not only affect the heart, but also can affect other organs of the body. And so it's very important to know about those because some of them have very different treatments. Some of them have very different prognosis outlooks. And so, for instance, I've listed some possible other causes, if you will, non-sarcomeric gene abnormality causes of an abnormally thick heart of hypertrophic cardiomyopathy in children. And so it is important to know these things, again, because treatment is different for them potentially, and outlook may be different. So this is, I think, is one key difference in pediatrics that is not always, not typically applicable in adults. So what testing and assessment do we offer to sort of figure this out? Well, certainly we're going to do a thorough history and examination of each patient we see, and certainly for even these screening visits. And history tells you a lot about an individual, and an exam has utility and is useful. We try to do at least 3-generation family history to screen for things that weren't maybe recognized as being hypertrophic cardiomyopathy, but in fact, when you put the puzzle pieces together, might suggest that. Certainly we do an electrocardiogram, so the heart rhythm tracing, an echocardiogram, which are, again, the moving pictures of the heart done with ultrasound. Sometimes we'll do what we say is a prolonged EKG assessment, which is you basically take home a monitor you wear for a day or 2 days or maybe 3 days, and it just records all the heartbeats over that period of time. And then we can look at those and we can say, there's something funny here. There's a heart rhythm abnormality. The patient did or didn't have symptoms, but this is concerning potentially, or maybe there's nothing there. And then sometimes we'll even do what I would term sort of on-demand EKG capturing, where, obviously there's new smart technology, smartphones, et cetera, but we also can send people home with monitors to use at the time of a symptom to see if that symptom correlates with a heart rhythm abnormality, which again may help us fill in the picture of what's going on. In addition, other testing that we offer is exercise testing, and sometimes we gather what we term metabolic data. So how much effort is being exerted through the test, how much oxygen is being consumed, and these are other markers that help get assessment of fitness. And sometimes we can add an echocardiogram with the exercise test. So stress echocardiography, looking for maybe there's no gradient, there's no narrowing of flow, there's no narrowing to the flow of the blood out of the heart at rest, but with stress, with exercise, there is, and that may impact decision-making around activities and treatments, et cetera. We have the capability of doing cardiac MRIs. So again, it's another way to look at the heart. Sometimes the pictures are clearer. It certainly can give us information about whether there is, as Dr. Estes referred to, LGE or possible scar or fibrosis in the heart. And certainly Dr. Wong is my go-to expert anytime I have a question, being a world-renowned expert in the field here of cardiac MRI in hypertrophic cardiomyopathy. And then genetic testing. We can utilize the results gathered from the parents and apply the appropriate testing potentially to a child. If a parent is known to have a sarcomeric gene abnormality that's been identified, well, then we just need to test those children for that gene abnormality. If they don't have that, they should revert back to the population risk of having HCM, which, as Lisa alluded to earlier, maybe as high as 1 in 250 to 1 in 500. But it helps us move the bar and say, this is somebody who we need to be seeing frequently versus this is somebody who maybe we don't need to see unless there's new information that arises. And then again, genetic testing fills a role potentially for some of those conditions that I alluded to earlier that are not the sarcomeric gene abnormalities, but do have genetic correlates that help us make these diagnoses of other conditions there. I think another sort of getting back to this theme of kids are not just little adults. So on this theme number 2 would be age influences the development and progression of the abnormality of the thickness of the heart. We can see severe thickness, severe hypertrophic cardiomyopathy at any age. So we can see it in newborns and in infants and in children, but sometimes we don't see it and it's not there. And it develops over time, and you need to have that careful eye to watch these individuals and see, do they have it now? Do they have it now? Especially if the data you have suggests they are at risk. So we use echocardiogram often, the ultrasound of the heart, to help us look at that. And we believe that in adolescence and teenage years, again, while it may develop at any time, even after teenage years, even in adults, the most common time that we tend to see this development is in the teenage years. And so it is very important to see those individuals more frequently. So at the bottom of this slide, we've just sort of laid out a rough assessment, and there can be some variability to this as to when we might see a patient who we believe is at risk for developing hypertrophic cardiomyopathy, but doesn't show that on their echocardiogram. So in a child, sometimes you might see them every 2 years, you might see them every 3 years. Again, depends a bit on the circumstances. When they hit the sort of adolescent growth spurt, 12 to 18-ish, we're seeing those patients at least once a year, typically once a year. And above 18, before we're able to transition them to our adult partners, we would recommend sort of every 3 to 5 years, depending again on other factors that may be going on. It's also important to recognize that age influences the ability to obtain some of those tests that I've just sort of mentioned that we're able to do, meaning a patient's cooperativity, right? A 2-month-old will generally sit still for an echo, particularly if they fall asleep. A 15-month-old, a toddler, they're not so into it. And so you might have to time your echoes and say, okay, I'm going to try to get my echoes up to about a year, because that's when that period of restlessness happens, and then decide if you really need that echo between a year and 3 years or 4 years. Again, it depends on the factors that are there. So and sometimes we have to do a very quick echo, look at a few pictures, get what you can get, make sure you feel like you've gotten enough, and that's what you're going to get for that attempt. Occasionally we do need to use medication to either sedate or just kind of take the edge off, and that sometimes works. Likewise, treadmill exercise tests. I don't feel comfortable putting a 4-year-old on a treadmill. I'm not going to get useful information, and they're probably going to hurt themselves, and that's not a great idea. So, probably you got to gauge each child differently, but age 7, age 8, probably that's where you're going to start to get meaningful information on a treadmill test that we would need to do and keep them safe. And likewise, MRI, while it may add vital information, you have to make a decision. Is it worth in a child who's young, who's, not going to be able to lay still for that MRI, you need to use general anesthesia. So am I willing to use general anesthesia to obtain that information? And sometimes the answer is yes, it's necessary. But but you have to ask that question and decide it may not be necessary. We don't need an MRI just yet. We can see well enough, and we can look a little later when I can get a cooperative patient, maybe age 7, maybe age 9, something like this, who can do what we need them to do in the scanner to get that information. So that's a sort of a caveat, I think, probably different than adult care. Talking about just briefly treatments and decision making. So I tend to think we offer the full spectrum of therapies. Again, we have the reliance on our adult partners for things that get a bit more challenging. I would say with the exception of alcohol septal ablation, which is generally, I'm not aware of being done in pediatrics, but we offer myectomy if necessary. We offer medical therapy as needed. We can obtain the testing as needed. We have individuals who have defibrillators when that's appropriate. So that is all possible, but it does have some challenges. A subcutaneous defibrillator, as Dr. Estes was discussing, may be better for young patients, but young in the adult world is different than young in my world. And it's very hard to get a subcutaneous ICD in a small individual, just there's not enough room there. So these are sort of nuances of pediatrics, but we do have the ability to place ICDs as needed when indicated. I think, in pediatrics, some of the most challenging decisions often revolve around sports participation. Many children derive a lot of who they are, who they hang out with, what they do around sports. And that's, and there's lots of good clearly to come from sports, but we have to be sure that that participation is justifiable, because there may be some added risk of a heart rhythm abnormality, of sudden death, or a significant event. So as, again, Dr. Estes had mentioned earlier, there's the concept of shared decision-making. It's very, we can say what we want, but if there's not buy-in, if there's not a discussion, that's not really what we need to do to be providing appropriate care. So it is really an important conversation to have. It can be a challenge. A 13-year-old may not see the big picture an 18-year-old may see the big picture a little bit more. I think as we all develop that maturity, we can remember what we were like as teenagers and as younger children, and there's an awareness and there's a sense of invincibility. And so how do we put all that together, have that discussion with the patient as at an age appropriate level, but also with the parent, providing the important information, making sure that we are not sugarcoating it, but, so that people really have the information they need to have to make a decision that is a key decision. So we do this, we attempt to do this, and sometimes these are very long and challenging discussions, and they may not happen all in one setting, but it is important to doing, I think, best care, and our team sort of takes that approach. It's also important to go back and re-review your decision-making and re-review where you are, because the information you have at age 7 or 9 or 13 may not be the same information that exists when somebody's 16 or 18 or 20, meaning maybe now there's a change in heart function. Maybe now there's more of a narrowing of the gradient. Maybe now there's more symptoms. Maybe somebody's had heart rhythm abnormalities we've never seen before. And all that might influence the willingness to say, yeah, go play any sport you want, or yeah, you can play sports, but let's think what we think could be a safer way to approach this versus, boy, we're really concerned that this is a very high risk situation. And so we need to share that with you and figure out how to look at the big picture and take the best care for the best outcome over time. So that's sort of the approach we take. I think I'll leave it there, and happy to answer questions in the Q&A. I just wanted to say thank you for your attention, and thank you again to the team for allowing us to participate. And I've put our nurse coordinator's contact information there for anybody who wants to take that down, and my email address if anybody wants to reach out. And I think with that, I'll turn it back over and stop sharing.
I am happy to say that I am comfortably on this computer now. The other one is still acting up. So welcome to my dining room again. Brian, thank you for an excellent presentation and a really important talk about, pediatrics. And they're not just little adults, like you said. I love the way you handled the sports participation. I do believe we're moving into an age where we can make some more individualized choices with clinical information and with the emotional well-being of the child and family in mind. So thank you for all those great comments. We do have a couple of questions on the genetics front. We have a question about somebody being her sibling tested positive. I'm sorry, I have a positive gene variant for HCM. I'm assuming we're talking about a pathogenic mutation causative for HCM. My sister tested negative. Do her children still need to be tested? Would Meredith or Brian or Tim or Kim
Should I
or
take
my
this?
cat? Yes, please.
So if your sister was negative, then we would say no, because if she didn't inherit it, then she would not have to pass on to her children.
So pretty simple question there. We just actually had a very
Great
interesting
question.
thing.
Great.
Yeah, it is. We had an interesting situation pop up in our community chat area. And that is an individual with HCM who had suspected her father was the carrier because he died at 44 of a quote heart attack, and her sister died at 49 of a heart attack, only to find out through the wonders of DNA that daddy wasn't daddy. So this is a cautionary tale of know your family health history as best as possible, and then be prepared for things to not exactly be as you thought that they were, because we find out a lot of people don't have the paternity that they think that they had. So part of our initiatives to talk about family health history is to see how much real data we can get. So these weird things happen. Lots of families have stories like this. So don't think you're incredibly unusual, but genetic testing can really elucidate a lot of things. So be prepared when you go ahead and do them, because the results may not always be what you think. If anybody else has any questions, they can put them in the chat box and we're happy to answer them. If my computer wants to let me know that I actually answered that one. We do have another diagnostic question that's been left hanging here for a little while now. So I apologize to the individual who posted it. It is anonymous. How common is it and I'm going to point this one to Tim, how common is it to get a false diagnosis of HCM by a cardiologist? And what is the exact diagnostic criteria for calling HCM HCM?
So, I think physicians are human beings, and things can go two ways. One is you can get a diagnosis of HCM, but you actually don't have HCM. And the other possibility happens as well also. You're asymptomatic but have HCM, and then it goes unrecognized. And then even sometimes when you do have symptoms, it can be unrecognized. So I think it really goes both ways. And that leads into, I think, well, how do you diagnose HCM then? And I think the best answer is the basics. You start with a history, symptoms, family history. Then you do ECG, imaging, and you really need to put it all together. And I think this is where, seeing the spectrum of cases at a high volume center can really be helpful in that, I think someone with a 3 centimeter thick septum, everyone's going to recognize that. But if you have a 1.5 millimeter or 1.5 centimeter septum and some hypertension that might confound the diagnosis, that's when you really, throw the kitchen sink at the patient and really try to tease out, is this hypertension? Is this HCM? And ultimately, it's hard for us to give numbers as to how often, misdiagnoses occur. But I think, the goal of, this whole tour is to, improve education and really, strive toward, improving, general knowledge and also, just how each center does things. And, I don't think, I'm sure we've all, made misdiagnoses. But from a patient standpoint, what I would encourage folks to do is if something doesn't make sense, ask your doctor, how they made the diagnosis. And then if that doesn't make sense, then maybe get a second opinion.
So I think the other thing I would add to that question is, who was the cardiologist? What was the quality of the imaging? Has it been evaluated by a center of excellence or an expert in HCM? Even with the existing images, you may not necessarily need to go for another echo, but have somebody else review the actual echo that was done, and that may prove beneficial. So David is asking a question in the chat area. Please use the Q&A box in the future, but we will address this question. Given the insurance and financial impact of HCM diagnosis, how do you balance those implications with having your children seen by a specialist as well and genetic testing? Well, the good news financially on genetic testing today is it's free. There are free programs for genetic testing, and we all know there's no such thing as a free lunch. So let me explain why it's free, because obviously there's somebody paying for something somewhere. There are a number of therapeutics that are available for what we call HCM phenocopies, or those diseases I talked about in one of my first slides, like Fabry's disease, amyloidosis, et cetera. And these are very expensive therapies. So the drug companies have a real motive to find those people. Interestingly, they hide within the HCM population. So something that looks like HCM may be something else. So they're the ones footing the bill for these genetics testing, with the caveat that when you agree to the genetic testing, all that happens is your doctor agrees that they will take a phone call from one of these sponsor companies to learn about the therapeutic options for something, let's say, like Fabry's disease. That's how it's getting paid for. So for the HCM community, it really is a free lunch because it's not going to impact us any other way. But for those of you who have another diagnosis, like Fabry's, amyloidosis, et cetera, maybe even Danon's disease, the sponsor company will contact the physician and say, hey, we want to let you know about this therapeutic option available for a patient that has recently tested with this gene that you ordered the test for. They don't know your name. They don't know the patient's name. It's all anonymized. But the doctor gets to know about the therapeutic option. So the genetic test is paid for, so you don't have to worry about that right now. But even if it were paid for by insurance, it's generally covered and it's not a problem. In terms of the finances related to screening families and copays and deductibles and the financial burden, thank you for asking. We're starting to conduct some economic evaluations of the burden of disease financially to HCM families. We know it's not just copays and deductibles. We know that it's lost time from work. We know that it's lost advancement opportunities or the inability to go back to college or to go back to education because you're just too tired at the end of the day. We are working with some teams to help figure out what that economic burden is, and then look for ways that we might be able to mitigate those things with accommodations in the workplace or accommodations through educational opportunities, et cetera. But first we have to define the problem. So we're hoping that you'll all join us in those efforts when they come up in the next few quarters. But we have some really great partners in crime on that one, and we're going to figure this out, and we're going to do all we can to help families live as well as possible with HCM. Some areas might include really advocating for preventative care to include screenings for families who have risks for genetic disorders. Every family with HCM is screening their kids, paying for echoes, EKGs, MRIs, Holter monitors every year or so. This gets really expensive. It should be viewed, in our view, as preventative care for these families. And Brian's nodding his head. And Brian, I'm going to tap you. Should be one of my advocates for that one. So we need to speak to the financial burden of disease as well as the physical and emotional. So that answered that, I think. If anybody has any other comments on financial impact, please comment. And we have another question coming in. More about the diagnosis of HCM if you're not eligible for life insurance and depending upon political environment with that, with pre-existing conditions. Your child could find themselves in a bad spot, or an individual can. So let's talk about genetic diagnosis for a moment. And Meredith, you can back me up here, please. We have something called the Genetic Information Non-Discrimination Act.
Correct.
Myself and many other advocates banged our fist in Washington back in 2006, 7, and 8, and we got protection, but it doesn't cover life insurance, but it does cover protection from pre-existing conditions. That's been fought a couple times, at the federal level. They tried to sneak in some language in the last couple of years to override that. It died on the vine. It never went anywhere, but it doesn't mean that it can't in the future. We are aware of that, but we don't think that anybody's going there because 75 million Americans have pre-existing medical conditions, most of which have genetic etiology. So we're also voters. What else can you tell us about this, Meredith?
Yeah, so the Genetic Information Non-Discrimination Act, or GINA, is a piece of legislation that is put into place to protect individuals who have genetic testing for certain things. So it does not protect for life insurance, long-term care, disability. It does protect for like health insurance, certain like other programs, but it's definitely not life insurance, not long-term care or disability. So our suggestions are always that if that's something that you're concerned about, make sure you get those things in place before you do genetic testing, because when they do those checks, like your life insurance, when they do those checks, they will find it. So get that into place and then do your genetic testing. HCM should not affect your premiums as much as something like Huntington's disease would, but it's still something that could affect it. So usually our recommendation is to patients, if that's something that they are concerned about when it comes to genetic testing, is get that done first and then have your genetic testing.
So we found many years ago that we were very afraid of those those gaps in GINA that didn't allow for life insurance, et cetera. We have found that gene positive can still get policies at a reasonable rate.
Yeah.
And clinically, once you're diagnosed, the rates go up a little bit higher. It is still obtainable for some. Defibrillators tend to make insurance companies nervous. I think it should provide them with reassurance. Mark, I don't know if you'd agree with me on that one or not, but I think we're trying to get them to listen to us. It's another area that we're advocating within. And I think that we will maybe in the next 5 years be able to see some comments there. One more comment on genetics, and then we're going to get over to Tim and we're going to hear the exciting stuff. Somebody and her brother have HCM. He was diagnosed genetically. He has children. They've been genetically screened. She does not have children. Is it important for her to get genetically tested? She's already clinically diagnosed.
I mean, we still recommend to our patients to have genetic testing if there's a known genetic variant in the family. I mean, that would be her personal decision. I'm sorry, did she have
She doesn't have children. So
no
it's-
children, but a clinical diagnosis?
Yeah.
Okay. I mean, that would be, if she has a clinical diagnosis, I think operating under the assumption that she does have the condition, so she would be managed like she has the condition anyway. I mean, the doctors can chime in if you would like. But I think as far as from a genetic standpoint, we would still recommend that she have the testing, but that would be a personal decision. If she's not going to have children, if she doesn't have children, not going to have children.
There's not a lot of downstream there.
Yeah, so I mean, that'd be, I guess, more of a personal decision if she wants to know that information or not.
Okay, thank you very much. Now we're going to get to the exciting talk. What's coming next? Tim, you want to share your screen and get us all excited about the future of HCM? Looking for that share screen button. I see the look on his face.
I think I have too many windows open, so.
It happens to the best of us, and God only knows what's happening in that other screen of my computer. I don't know. There you go.
All right, so thanks so much for the opportunity again, Lisa. And I'm trying to keep this short and sweet, but at the same time, try to answer a lot of the questions that have been coming into our clinic. I've been glad to be part of multiple clinical trials looking at some of the novel medications coming down the pike. And it's a very exciting time to be in the HCM field. So I'd like to just start off with a brief recap of what we have available currently for our patients, and then talk about some of the upcoming drugs in the pipeline that have shown a lot of promise for both obstructive as well as non-obstructive HCM. And I think this segue is to remind me to focus on just this really important category of how we classify different types of HCM patients in terms of how their hearts are behaving. So I have an example of what we would term obstructive HCM on the movie here. You can see that this is a very thick heart, and that during systole, when the heart contracts, the mitral valve and the thickened interventricular septum essentially come very close to each other, and the blood inside the left ventricular cavity is obstructed as it's trying to get out into the aorta to supply the rest of the body with blood and oxygen. So symptoms of obstruction include shortness of breath, chest tightness, especially with exertion, decreased exercise capacity, and other less common symptoms like dizziness or even palpitations and things like that. So from a definition standpoint, if you ask your doctor how obstructive you are, we often use a term called the left ventricular outflow tract gradient, which is just a way that we can measure the pressure difference before and after the obstruction. So if we say that the peak gradient is above 30, that's typically about the threshold that the amount of obstruction required to generate symptoms. And that from a severity standpoint, the guidelines recommend that we be able to demonstrate a gradient or a level of obstruction greater than 50 millimeters of mercury before advanced therapies such as open heart surgery or ablation be considered. And then a final reminder is that of patients with obstructive physiology, only about a third of them can we identify the obstruction through provocation, meaning that with resting imaging, we don't see an obstruction, and we either have to give medications like amyl nitrate or put someone on the treadmill and exercise them to unmask the obstruction. But even this labile obstruction can cause symptoms, and it's really important to correctly identify, Are you obstructive either at rest or with provocation, which would put you into the obstructive group, or are you a non-obstructive hypertrophic cardiomyopathy patients? So if you're obstructive, we use first-line medications, typically beta blockers or calcium channel blockers. And what both of these classes of medicines do is that they can slow down the heart rate, decrease the amount of contraction that the left ventricle does slightly, so that it opens up more room in the outflow tract so that more blood can get out and relieve symptoms in that manner. If these first-line drugs are insufficient to really treat the symptoms and really decrease the obstruction, we have a second-line option, which is a medicine called disopyramide that was initially developed as a heart rhythm medication, but what we found over time was that this medication can also relax the heart muscle in a very potent manner and then decrease the amount of obstruction to blood flow. So this is just a picture diagram where we can use something called Doppler, which is kind of a way of using sound waves to measure how fast blood is moving. And the faster the blood is moving through the outflow tract, then correlates with how much of a pressure difference or gradient there is caused by the obstruction. So this is a patient who is already on first-line medical therapy and who has an obstruction of around 68 millimeters of mercury, definitely very obstructive and symptomatic. We then started disopyramide on this patient, and after several months on disopyramide, you can see that the obstruction, the velocity of the blood flow is about 4 times reduced, and the peak gradient in this patient now is about less than 10 millimeters of mercury, even with bearing down and trying to provoke the obstruction in a mild manner. So, there's definitely, good options from a medical standpoint available for obstructive HCM. But if these are insufficient to really, manage the symptoms completely, the most aggressive approach would be open heart surgery, in which the hypertrophied septum is then excised. And sometimes a mitral valve repair is done at the same time also if the mitral valve has some floppiness to it that would require some repair to prevent reobstruction after the surgery. For patients who are at high risk for surgery, or for patients who, there's a good reason not to consider surgery, we can consider alcohol septal ablation, which uses a heart catheter-based technique to engage one of the arteries that's feeding the thickened heart muscle. We can isolate that with a balloon and then inject alcohol into it, which causes a small heart attack. That heart attack kills some of the heart muscle cells, which then shrink over time, and then can relieve the obstruction by decreasing the amount of heart muscle that's in the outflow tract. So just as a pictorial example, this is a patient that on the left-hand image shows what the heart looked like before septal reduction surgery. In this case, it was a myectomy. You can see about a 2 centimeter thick septum, severe obstruction with the mitral valve touching the septum during contraction. And then after the myectomy, you can see that a nice chunk of the heart has been shaved out and that the outflow tract is wide open. And this patient went from not being able to walk to the bathroom without getting short of breath to now living a very full life. Now I'm going to change the topic slightly and then talk briefly about non-obstructive HCM. So we have an example here. This is a very thick heart. This is a cardiac MRI showing the left ventricle here, the muscles in dark gray. But if you notice, as the heart contracts, the outflow tract remains wide open. There's very little turbulence here. The aortic valve is opening normally. And this patient has what we call non-obstructive HCM. The symptoms often mimic obstructive HCM. They're the symptoms of heart failure, shortness of breath, chest tightness with exertion, fatigue, and sometimes even congestive heart failure symptoms with swelling in the legs and other parts of the body. And again, we really want to make sure with provocation that we're not missing labile obstruction that can only be unmasked with certain maneuvers. And we'll see why it's so important, because the therapy for non-obstructive HCM is really limited. If you go back and look at the guidelines, they say, well, look at the section for treatment of symptomatic non-obstructive HCM. And there's only a few suggestions. You can try beta blockers or calcium channel blockers to slow down the heart rate and decrease myocardial oxygen demand. You really want to try to make sure that the volume status is okay. They're not too wet, not too dry. And if they're wet, you can try some diuretics. But then all of a sudden, the guidelines talk about heart transplantation, meaning that if someone has severe symptoms from non-obstructive HCM, you've tried medical therapy, then one of the few alternatives remaining is a very aggressive heart transplant option. For some of our patients, we've, out of desperation, used off-label indications for certain drugs that are already clinically available, like nitrates, ranolazine, pyridostigmine, and other drugs with, I'd say, middling success. But because a small number of patients clearly feel better, we'll still give these a shot just because there's really no other good medical option to offer them. And many of them are just not sick enough to be able to compete for a heart transplant. So, I think in part because, the non-obstructive HCM arena has a huge unmet clinical need, as well as the fact that many patients do not want to go for septal reduction therapy. There's been a lot of research over the years on, just other alternatives from a medical standpoint regarding other therapies for both forms of hypertrophic cardiomyopathy. And this slide is just to show you that there's been many attempts, mostly without much success until recently. And I think this is where the fun part of being in the field is now starting to emerge. And a new class of medicines is now being clinically developed, initially for obstructive HCM, but with potential applications for non-obstructive HCM. So I think, Meredith and Brian and Lisa alluded to earlier that HCM is often considered a disease of proteins that form up the sarcomere, the part of the heart muscle that allows for contraction. And a couple of the key proteins are actin and myosin. And these form links that then allow these fibers to slide in opposing directions and shorten the heart muscle, and that's how the heart muscle creates a contraction. In many patients with HCM, mutations in certain of these genes lead to a conformation of these cross bridges, which is more active, meaning that you can see more crosslinks here that then lead to hypercontraction, a higher than normal systolic function that can lead to the HCM phenotype, including obstruction to blood flow. With the addition of a myosin inhibitor, these additional crosslinks are then inhibited, and we can try to then approximate the normal number of crosslinks and decrease the hypercontractility of many of our patients. And, as I'll show you later on, can then impact clinical symptoms and clinical outcomes. So moving on from kind of a mechanistic approach to, just what does the data actually show? The first study I'd like to briefly go over is the Explorer HCM study, which looked at mavacamten in the obstructive HCM population. I use this slide as part of our fellows boot talk, but I always try to remind myself that not everyone is really wants to go into this as much in depth. So I've provided this kind of like, I think, more simple summary. So this study really looked at patients who had symptoms from obstructive HCM. And the main outcome that the study looked at is, did the aerobic capacity, the ability of the heart to turn oxygen into carbon dioxide and water through exercise, or the functional class, how much activity the patient is able to do, whether these metrics improved in response to exposure to mavacamten. So the end result is that for patients in the drug arm, 37% of them had improvement, whereas in the placebo arm, only 17% of them improved over time. And this suggests that, this difference in response rate suggests that there's a causal effect in terms of mavacamten exposure to help improve the heart function and the patient's symptoms. From a mechanistic standpoint, this study was also able to show that this improvement in symptoms and function occurred alongside decrease in the amount of obstruction, so that on average patients dropped their amount of obstruction to blood flow, the gradient, by about 47 millimeters mercury, which is clinically a very substantial number. And these we can, I'm happy to answer in the question and answer section, more specific questions. But I think, this really summarizes the overall aims of the study. So we've talked about obstructive HCM. What about non-obstructive HCM, which definitely appears to have more of a clinical unmet need in terms of a number of clinical options that we can offer our patients. So the Maverick HCM study is a more preliminary phase study. This is a phase 2 study that was mainly looking at safety and tolerability, with some look at whether there was any efficacy in terms of helping improve the cardiac status. So the overall findings was that the safety and tolerability was very similar to placebo, to a sugar pill, and that more interestingly, when you look at certain blood tests that we commonly use in cardiology to get a sense of how good or bad the heart is doing, what the volume status of a patient is, there were significant improvements in a blood test called B-type natriuretic peptide and also troponin. And both of these are released by the heart in response to heart failure or to heart injury. And then as another, kind of secondary endpoint, the study also did look at patients, whether there was any clinical benefit. And in a subgroup of patients with the worst markers at the start, a third of those patients on mavacamten had some clinical improvement, whereas no one in the placebo arm had any clinical improvement. I think we need to interpret these findings with a little bit of caution, and that the overall goal of this phase 2 study was to look at safety. But I think these subgroup analyses offer some very tantalizing data as to potential applications of mavacamten beyond the obstructive HCM arm. But I think further studies are definitely going to be needed before we can be convinced of their utility. There's a second myosin inhibitor also under development a little bit later on in terms of the timeline. So there's a phase 2 clinical trial of aficamten, which is also a myosin inhibitor. And this is just a copy from a recent press release showing that aficamten also successfully reduced LVOT gradient, and that in general it was fairly well tolerated. And there should be a phase 3 trial for this medication later on this year. So I think one common question that we've been getting, in addition to, should patients be started on this, medication, is, what are the side effects of this class of medications? And as the mechanism might suggest, by reducing the number of actin myosin crosslinks and decreasing the contractility, higher doses of this medication may lead to inappropriate weakening of the heart muscle. And this is, sometimes seen in these studies. But I think the good news is that cessation of this drug typically leads to resolution of the drop in ejection fraction, or how strong the heart muscle is doing. And so, one anticipated caveat for use of these medications that if the FDA does approve this class of medications later on, we'll probably need to monitor patients on this medication fairly closely just to look for this, potentially adverse side effect. Just a quick look at the field. It seems like 10 years ago there were very few trials looking at HCM, and all of a sudden there's a renewed interest in this fairly rare but still relatively common disease. And there is Imbria that Lisa Salberg mentioned too will be I think advertising for a new trial looking at non-obstructive HCM, and I'm not going to discuss the mechanism of this IMB 101 drug. I'll leave that to Lisa's webinar. And then there's also even look at sacubitril valsartan, which is typically used in the systolic heart failure or dilated cardiomyopathy population, and whether there might be any applications in HCM as well also. And then finally, beyond the scope of tonight's talk, is that there's multiple gene therapy studies underway that are very preliminary, not really very many ready for late stage human trials, but definitely a lot of activity in this arena, both looking at changing protein expression, changing mRNA, and also even gene editing as possible solutions to changing the effect of a misspelling in the DNA of a sarcomere gene. So I think it's been really exciting in this field to, have kind of joined this field about a decade ago, and really, having a limited armamentarium and often reaching for the ablation or surgery, advanced therapy option, to now learning about, different solutions to the problems of obstruction and of stiffened heart and diastolic heart failure in the HCM population. I think the take-home message is that I think the bread and butter still remains very efficacious, so that if you have obstructive HCM, there are many options I think are available for each patient to talk with their team about and decide, with a really transparent discussion as to when to reach for some of these strategies. But that if the advanced strategies are not really part of a patient's preferences, that there's emerging hope that there will be other options available. As Lisa mentioned, we should hear some news from the FDA sometime this winter. We remain hopeful that there will be applications developed for a non-obstructive HCM, and that some of these medications may also prove efficacious in improving heart function, and also equally importantly, clinical outcomes in the non-obstructive HCM population. And that we just have to really be careful as these new drugs roll out, to be cautious about unknown side effects and also long-term outcomes. But I think we're really encouraged by the new activity in the research and development sphere, that HCM is now the focus of multiple efforts looking for new solutions. So I just want to provide some additional acknowledgments. It really takes a team to be part of this effort. And I just want to thank our patients who may be listening on the call. I apologize for Pittsburgh traffic and construction at the hospital. Thank you so much for bearing with us. And again, thank you to Lisa for working with us over the past decade. And lastly, just to thank our administration for giving us some extensive administrative support to make all of these collaborations possible. So with that, I'm going to turn it back to you, Lisa, to help moderate some of the questions. Thanks again.
Thank you, Tim. That was an excellent talk. Even though my allergies don't want me to talk, I'm going to. We do have some questions here, and I am going to, oops, you want to do your stop screen share? I'll just kick that out there. We're going to give our first question over to Mark Estes. We have a complicated device question, but one that I think is something that a lot of people are going to be dealing with moving forward. So somebody has a traditional ICD, it's coming to end of life, and the leads are now scarred over, and it appears that there might be a lead issue. So the question is, do we leave leads in place and go to an SICD with the old leads still in place? Do we try to drop in new leads? What are some of the options for patients when they're looking at device replacement after long periods of time? And this individual is currently in their 40s.
Yeah, so this is a scenario that's coming up increasingly, and there are a number of options. One of the options is to replace the existing transvenous lead by removing the old lead and putting a new one in. Now, the removal of the old lead with that scarring that they've referred to has some risk. It's in experienced hands, not a substantial risk, but there is a risk. It's a risk of damage to the blood vessels, damage to the heart muscle that might require open heart surgery. If that lead is removed and a new one is placed, you still have the intravascular lead, which is subject to all the stresses, wear and tear, and failure rates are probably going to be about 60% at 20 years, and the risk of infection. So that needs to be one option. The other option is to put a new lead in, leave the old lead there. That subjects one to less risk with the extraction. However, there's still the risk of infection, which might be even higher with two leads in place or more, and also the risk of obstruction of the blood vessels, particularly if you've got an atrial lead and two ventricular leads, or even a left ventricular lead, the risks go up. What we are commonly doing in that situation is abandoning the old lead. And we'll do that sometimes. We'll take the old defibrillator out that's reached its end of life and might have 90 days of battery life left, cap that endovascular lead and put a sub-Q device in if they don't need pacing. We think that that's a better long-term strategy. Having said that, it's without, at this point, the capacity to pace people. So there are a number of options. I think that one of the best approaches that I typically go with is to take the option that has the least risk. And I think in that respect, many times we're actually just letting the old device stay in place, let the batteries get depleted, don't remove it, leave the lead there. The transvenous device is non-functional, and we just put a subcutaneous device in without even removing the old lead. The risk of putting the subcutaneous lead in are very, very small because we're outside of the chest cavity, outside of the vascular system. And I think you'll be seeing this more and more in the future, abandoning old transvenous and going to sub-Qs. So good question, but it has to be individualized by the patient with their physician as to what makes the most sense for them.
Follow-up question on that, Mark. There's no interaction with the leads, for the internal leads versus the SICD. There's no negative consequence there.
So, it's a great question. It's something that we weren't worried about too, is that because you have a device here and a lead here, is the intracardiac lead going to shunt some of the energy? And the answer is no. It doesn't serve as a sink. The only way that it would do that if it weren't properly insulated, okay? But it's insulated because when we take the device out, we cap the lead and it's insulated, or we leave the device there. So there's no difficulty putting a subcutaneous device in with people with pre-existing transvenous leads in terms of interaction or raising defibrillation thresholds.
Fantastic. Okay. So Anonymous, you had your question answered live. I hope you found that informative. Okay, next question is about the Explorer trial. And specifically, Tim, if you could speak to this, and I'm going to do a little, when you're answering this question, I'm going to go into the other room and stop the Facebook feed. So we're going to be ending Facebook in just a moment. I hope, God, I hope we don't kill the rest of this webinar, but we'll see what happens. Can you just discuss an Explorer? Was there a reduction in LVOT in all patients or just patients who showed improvement? And additionally, can you speak to some of the numbers and LVOT reduction overall in the trial? And I will be right back. Tim, you're on mute. Go ahead.
All right, hopefully I'm off mute. So to Andrew, who asked that question, I should have responded on the Q&A with some text taken from the trial itself. But I think the simple answer to your question is not everyone had a dramatic drop in the obstructive gradient, and that the numbers that are reported are what we call aggregate or mean numbers. So you take everyone in the trial who was on mavacamten and you average out the response to mavacamten. So some people had a huge response, some people had a more modest response, some people had likely minimal response, and the drop of 47 it represents like a mean or an average for those numbers. But if you look at the text box, I should have been able to copy the exact numbers. But I think in terms of, if you look at the number of people that dropped to a gradient below 30, I think almost 30% of patients who had mavacamten and Explorer dropped to below 30. And the exact numbers I copied into a response to you in the question section. So, I think the overall take is that mavacamten, works, but, it may not work for everyone. And we just have to see on an individual basis, how the response is.
Okay. I'm not sure where Lisa is. I think she's probably just trying to sort out her technical difficulties. Oh, there she is.
I can't stop Facebook. So Facebook is going to record anybody who has questions that they don't want to go live with. They're going to have to email us, and we will contact you offline with your answers. You can email to support@4hcm.org, and we will get you your answers tomorrow. I am terribly sorry about the technical difficulties we're running into here. Okay, next question. You missed the first part of the meeting. Is it available to view anywhere? It's currently available on Facebook, and you can go view it from any point, and you can view the entire thing on Facebook now. And then it will be on our YouTube site in a couple of days as well. Another question, since beta blocker brand name label pricing has drastically increased, specifically Toprol, are there recommendations to shift back to generic versions of these drugs? I don't know how much the UPMC team is involved with some of the problems with generic drugs. Tim, is this something that you guys have been following?
Yeah, so, I consider Harry Lever one of my mentors, and we definitely have experienced, cases of patients who clearly did better on brand name Toprol versus generic metoprolol succinate. There used to be Eagle Pharmacy down in Florida that had a really good deal if you just paid cash for it. And for many years, our patients who really did well on brand name, use that option, which I've heard from patients is no longer available. And
let me validate that a little bit. So I do have an update there. Eagle Pharmacy is back, kind of. So AstraZeneca, who makes Toprol, gave their official generic license to a company called Lynette, and that's where this discount price came from. Lynette stopped manufacturing it, or stopped the approved generic, and it was sold to a new company called New American Therapeutics. New American Therapeutics made the Eagle Pharmacy program available again, but doubled the price. And it's now $40 a month for a 25 milligram prescription cash pay. And for 100, it's about $100 a month. So this was a problem because New American Therapeutics was only distributing through Eagle and only distributing for cash. That wasn't their deal, I don't think. And AstraZeneca has asked them to start making it available in all pharmacies. And about a month and a half, 2 months ago, it started to become available at CVS and Walgreens. So you're going to want to check with your manufacturers. There is a study going on right now about not only dissolution rates of generic drugs, but also active ingredient. The active ingredient doesn't seem to be the problem with a lot of generics. The dissolution rate and how it breaks down in your body and how fast it absorbs, that's the problem. So you get a big peak of something and then you drop off. This was proven also with tacrolimus, which is a transplant med. But in our cases in transplant, it can be deadly when you drop too low, as opposed to just keeping your heart rate not at the proper level. So there are some studies I'm aware of, and there should be some publications in the next couple of months on these matters that will show which manufacturers have problems and which ones don't. And hopefully we can get the FDA and our government to do some better inspection on the quality of the drugs that are in this country. Tim, back to you.
Yeah, so I think from a practical standpoint, for patients that are having trouble getting brand name Toprol at a reasonable price, we've been doing kind of what we call N of 1 experiments, meaning that we have you switch to something that you can get and really, pay attention to symptoms. And if there's a clear difference, we've been, petitioning insurance companies to say, there's a suboptimal effect clinically with this medicine. We've tried several generics, And, we are, humbly requesting, better coverage of the brand name option, just to improve that patient's quality of life. It's worked with some insurance companies. It has not worked with others. And I have to give a shout out to Kim, who has been a saint in kind of helping our patients navigate that process.
Okay. Last question that's in here. And if you have any questions, speak now or forever hold your peace. But if you don't want to ask it publicly, you can ask the question anonymously. If you don't even want to do that, you can email us and we'll get to answers as quickly as we can. So this gentleman has had 2 myectomies about a decade apart, 2010, 2019, and has no residual gradient after the second. Is there any reason to consider new medical therapies when they're approved if he doesn't have obstruction? I would ask Henry, are you symptomatic? Is your quality of life impaired? And if so, that's going to depend, that's going to alter the answer you're going to get. So let's just say, for reasons of generalizing the question, let's say you're still short of breath and you're having maybe a little bit of diastolic dysfunction. Tim, do you think he should look at any of the new meds?
So I think if there's no obstruction and there's symptoms, we would classify that patient as having non-obstructive hypertrophic cardiomyopathy, no matter whether there's a myectomy in the past or not. And I think if there are symptoms, then there is intriguing preliminary data from the Maverick trial that mavacamten, might have some clinical benefit, although that study was not powered to really prove that point.
No.
I'm hopeful that there will be a follow-up study with more patients to answer that question more definitively. And then, but let's say, the patient's symptomatic and, we don't have the results of the trial yet, then I think it would really need to be a one-on-one discussion as to, how symptomatic the patient is. Do they want to give it a try? Should mavacamten be, released clinically? But then it would be in what we call an off-label use of mavacamten, meaning that mavacamten, as of right now, if it gets approved, will be approved for the indication of treating symptoms due to left ventricular outflow obstruction. But could an off-label use be considered? It could be, but then you get into issues of will insurance cover it? How much will it cost? What's the risk benefit to the patient? So I think it will ultimately need to be a one-on-one discussion.
I agree. I do have one final question that I'm going to hit to Mark regarding MRIs. So we went through the generation of ICDs and MRIs. Absolutely not. Don't even go near the room. And now there's new guidance that says MRIs and ICD are safe, even with abandoned leads potentially. How do you weigh in on MRIs and ICDs?
Sure. Yeah, it's another important question. Certainly for the last 3 to 4 years, every pacemaker, defibrillator, and lead that has been put in is MRI compatible, as long as it's a system from the same manufacturer. So for people with recent implants, you're covered with MRIs. For people who have what we call legacy devices that may have been put in with the lead or with the device that preceded MRI safety, we've learned that these can be safely scanned if appropriate precautions are taken. And increasingly, we're learning that abandoned leads can be scanned as well. There are protocols. These protocols vary by institution. Some institutions will only do MRI manufacturers' safe systems. Others will do legacy devices. Others will do abandoned leads, but it's variable by institution. What's important is that these devices be evaluated prior to the MRI by qualified people, and we have a program here at UPMC where we get all the information, review the x-rays, review the data, actually go and program the device prior to the MRI, and then immediately after the MRI, interrogate it, whether it's MRI compatible, whether it's a legacy device, or whether it's an abandoned lead. So many centers have this capacity, but not all centers. Given the importance of risk stratification with LG and the hypertrophic cardiomyopathy patients, I think almost all hypertrophic cardiomyopathy centers are going to have the capacity to do MRIs safely in individuals, even if they are legacy devices. But Tim, tell me about the MRI and the image quality with people with defibrillators in place, either with endovascular leads or sub-Q leads. Can your image quality be adequate with the MRIs that are done with LGE and the hypertrophs?
So I think you bring up a really important point. One is, can we MRI the patient safely? And then the second point is, do we get useful information from the MRI itself? So I think from a practical standpoint, there are pulse sequences called wideband late gadolinium enhancement pulse sequences that really take away a lot of the artifact from the metal that's safe to scan, but can still obscure parts of the heart. And it's a question that, for our patients that get MRIs at other centers, we literally write on a piece of paper, is wideband LGE available that will, really enhance the chances of getting a diagnostic study. The safety is not of concern. The question is, will we actually be able to see the heart? But these sequences are, in part commercially available. And if they're not commercially available right now for that particular machine, they should be shortly.
Fantastic. That has been a big question lately at the HCMA, as most people want to get MRIs, but can they, number one, and secondly, are you going to get anything usable out of it? Because they're not exactly what I would call fun events to sit in an MRI for 45 minutes. So you want to make sure it's worth it. So that was fantastic. I thank you all for your contributions today. I do want to take a moment. I mentioned this briefly at the beginning. The HCMA does attempt to hire from within the community when we can. So a number of our staff members are actually HCM warriors as well. And today's kind of a big deal because I'm just looking at my Facebook here earlier. And 3 years ago, Amy was walking down the hall with a walker and her new heart on board. And when you're a heart transplant patient and you've achieved 3 years, it's kind of a big deal because while you're never fully out of the woods with a transplant, 3 years is a milestone. So congratulations, Amy, on making it 3 years. I know your mom is smiling down on you. And for those who don't know, Amy's mom was my original mentor, as she was the founder of the Cardiomyopathy Association in the United Kingdom, and a woman who I found during my journey. And then Amy moved back to the United States and lots of things happened. And now she's part of the team and part of my family. So congratulations on your 3 years, Amy. I'm really happy that we've gotten this far, and it's kind of a big deal. So Tim, Mark, Meredith, Genise, Kim, and Brian, who left, thank you so much for your participation tonight. We're going to close this meeting, and I'm going to hope that the Facebook feed ends, or the Facebook feed will go on forever. I just don't quite know. Thank you all for participating tonight, and please do complete the survey that you will be getting in your email tomorrow, and let us know what you thought of the event. And if there's any other topics you'd like to hear us cover in a future event, please join us. Upcoming events for Bighearted Warrior Tour October, we have a special version. We are going to have updates from the International Summit on HCM directly from the directors of the program at Tufts. So please join us in October for that edition. And in December, we'll be rounding out the year with our friends at Barnes Jewish in St. Louis. And we have a whole big agenda for you next year. So don't forget to start marking your calendars early for these events. They'll start populating our calendars shortly. Thank you all again. Have a wonderful night. Stay safe, stay well, and have a good day.
Night.
Thanks, guys. Wait, let me do that. But I can't stop streaming on Facebook. I'm leaving. Bye.